Hello, my name's Stefan Morgan. I'm a dual ICM anaesthetic registrar currently working at UHW. Welcome to the next presentation of these Introduction to ICU presentations. In this summary, we're going to talk about one of the mainstay topics of ICU, shock and vasopressors. So by the end of this presentation, you'll have a better understanding of the following: a definition of shock, a little recap on the pathophysiology, which then will hopefully link in with how we manage it in the later parts of the talk. The types of shock that occur and how these clinically present and manifest themselves at a physiological and clinical level, which again should help you to differentiate when you're reviewing patients either on the ward or in the intensive care. How we assess for shock, and then we'll go on to look at some of the mainstay treatments for shock that we encounter on the ITU rather than just ward-based care. This is where we'll then go on to talk about vasopressors, where we will cover some of the basic physiological and pharmacological principles of vasopressor administration, and look at the common vasopressors and ionotropes that we encounter on the ITU. So what is shock? Unfortunately, there is no consensus definition, but broadly speaking, shock is a life-threatening, insufficient supply or utilisation of oxygen at a cellular level. It's usually the final common pathway of many different underlying pathologies, but if untreated, can result in cellular hypoxia, progressing to organ dysfunction, multi-organ failure, and death. It is often the organ dysfunction to multi-organ failure stage where we as intensivists may pick these patients up. In the UK, shock is the most common cause of admission to ITU, with the aim being prompt recognition, treatment and prevention of progression to multi-organ failure and death. So how does shock occur? Without delving too far into our physiology textbooks, we're going to have a look at one simple equation, the delivery of oxygen. This states that delivery of oxygen is equal to our cardiac output times our oxygen content of arterial blood, which is made up of hemoglobin saturations and the dissolved oxygen within the blood. If we take the arterial oxygen content as constant, as this can be quite difficult to manipulate other than maximising our oxygen saturations, then cardiac output will be the main determinant of oxygen delivery. As you may know, cardiac output is a product of heart rate and stroke volume, with stroke volume being dependent on three main factors: preload, afterload and contractility, which you may be familiar with. For most causes of shock, one of these will be affected to reduce cardiac output. It's worth mentioning that septic shock is slightly more nuanced. We now have a better understanding that often cardiac output may increase in septic shock. However, VO2 also increases, and there's now a better understanding of inadequate tissue perfusion at a microvascular level due to a number of different inflammatory and ischemic reasons. Generally, we can break shock down into pump, pipes or tank failure, or more simply, loss of preload or loss of output. Broadly speaking, there are four main types of shock, although as mentioned, two tend to affect the ability of the pump to work, which are cardiogenic and obstructive shock, and two affect the amount of volume there is to pump out. They are hypovolemia and distributive, although as mentioned in the previous slide, septic shock, which forms a type of distributive shock, is slightly more nuanced, and you may see an increased cardiac output, particularly in the earlier stages. We'll now go on to break down each of these categories, their common causes, and the physiological effects they have, which will give us the rationale for the different ways in which they are treated. Obstructive shock results in loss of cardiac output due to impaired ventricular filling or ejection against a high afterload, which impairs cardiac output. The cause of this can be broadly classified into intravascular or extravascular. Common intravascular causes include thromboembolic events, such as PE being the most common one. The extravascular causes are things which result in compression or obstruction to the outflow of the major cardiovascular system, such as tension pneumothorax, cardiac tamponade, or severe asthma, where high intrathoracic compressions can result in impaired ventricular filling. These diagrams represent how some of the common causes of obstructive shock, such as tamponade and tension pneumothorax, impair ventricular filling due to compression, whilst PE prevents right ventricular outflow, resulting in right ventricular dilatation and impaired left ventricular filling, which again results in reduced cardiac output. Hypovolemic shock is most commonly caused by bleeding, and these can be further broadly classified into non-traumatic and traumatic. The non-traumatic causes that we may commonly think about would include upper GI bleeding. Other causes include excessive fluid loss, such as GI losses, although this is less common in the developed world, burns, DKA, iatrogenic causes, and the compartmental fluid shifts seen in acute diseases such as pancreatitis. The loss of preload results in reduced cardiac output. As a result, the systemic vascular resistance initially increases to try and maximize cardiac output along with the heart rate. This slide shows the classes of hemorrhagic shock and how they may present clinically. As you can see, initially we're able to compensate very well for hemorrhagic shock via a number of different tumoral mechanisms to restore intravascular volume. This is why using blood pressure as an indicator for blood loss can be a poor marker, as it is often a late sign of significant loss in these patients, and there are much earlier clinical signs such as heart rate, resp rate, and urine output that may indicate significant loss and allow us to intervene much earlier. Cardiogenic shock is as the name says on the tin and results in failure of the heart to eject sufficient blood to provide adequate end organ perfusion. This can be due to impaired contractility, which is commonly a result of myocardial ischemia, brady or tachyarrhythmias, valvular failure, or intrinsic obstruction to the left ventricular outflow tract. The failure to eject blood results in a decreased cardiac output. Preload remains high as the volume is not ejected, and stroke volume is low. As a result, the systemic vascular resistance increases in order to try and improve cardiac output. This can actually further impair cardiac output by increasing the afterload of the heart. All of this results in poor end organ perfusion as well as poor coronary perfusion, which can cause further myocardial injury and exacerbate the situation even further. A build-up of pressure within the left ventricle can also impair gas exchange in the lungs as a result of pulmonary edema, and this pressure can also be transmitted to the right side of the heart, which results in increased venous pressure and impaired perfusion pressures at an end organ level, which can further impair perfusion. This is represented in the diagram below. There is a classification for cardiogenic shock, known as the SCAI classification, with A, B, C parameters based on severity of clinical features, and helps identify patients as they move down towards the E level, with evidence of poor peripheral perfusion. So A identifies patients who may be at risk, but not really eliciting symptoms of cardiac failure at that time. B is the beginning, and it's a patient with clinical evidence such as hypotension and tachycardia without evidence of organ failure. C is our classic, and this is a patient that manifests with hypoperfusion that requires initial intervention. D is a deteriorating patient. Again, this is similar to category C, but this is a patient that has failed to respond to the initial interventions that we may have tried based on the underlying cause. And E is a patient that is in extremis, that is experiencing cardiac arrest with ongoing support via multiple interventions. So it is probably the patients in that B to D zone that we'd hope to intervene early with in the intensive care unit. And we will go on to discuss the ways in which we may be able to provide support. It is worth mentioning that obviously treating the underlying cause is the mainstay of initial treatment. The last and possibly the most common type of shock you will encounter on the ITU is distributive shock. The three main causes of this are septic shock, anaphylactic shock, and neurogenic shock. Generally speaking, distributive shock is caused by a loss in vasomotor tone. This results in a drop in systemic vascular resistance, which manifests as a drop in blood pressure or mean arterial pressure. This causes a drop in end organ perfusion due to a poor distribution of blood flow, as well as a reduction in preload and therefore cardiac output. As I mentioned previously, there's now a better understanding of the pathophysiology of sepsis at a microcirculatory level, which shows that there are other mechanisms such as microvascular thrombosis and ischemia, as well as endothelial damage and capillary leakage, which can also affect end organ perfusion. Aside from treating the underlying cause, these patients will often require pharmacological therapy to support their drop in systemic vascular resistance and mean arterial pressure. This will help to improve cardiac output and thus end organ perfusion, and we will go on to discuss these pharmacological therapies a little bit later on in the presentation. Undifferentiated shock can be one of the biggest conundrums for the ITU clinician. I'm going to talk briefly about a general approach to assess a patient with undifferentiated shock at the bedside. We shall assume that any clear reversible causes such as anaphylaxis, hemorrhage, etc. are being treated. As per usual, the approach will follow an ABCDE structure that you're all familiar with. I'm not going to dwell on A and B too much, as primary issues with either of these are likely to cause inadequate tissue perfusion via hypoxia rather than inadequate delivery that we would usually associate with shock. It is worth mentioning that optimization of both A and B components will be required during early stages in your management, although this may not be the immediate priority and may occur following stabilization. The C aspect that is going to perform your mainstay of assessment in this instance, as it's not only going to give you an idea of the cause, but also the severity of the shock you're managing. The clinical presentation we typically associate with shock is that of a peripherally shut down patient with cold extremities and a prolonged capillary refill time. They're often tachycardic with a low blood pressure or mean arterial pressure. The increase in heart rate is due to the heart trying to compensate for a reduction in stroke volume or to improve the cardiac output. This is probably something that as residents you've all encountered on the wards. What we would like to ascertain at this point is what aspect of the circulation is leading to the poor peripheral perfusion, so that we can begin to understand how we will appropriately correct it. A more detailed look at our clinical examination may offer points of differentiation. Generally speaking, the patient will be cool with a prolonged cap refill. However, in the early stages of septic shock, a patient may be warm and flushed with a brisk capillary refill. They may also have a bounding rather than weak thready pulse that we would classically associate with other forms of shock. This is because of the hyperdynamic cardiac output initially seen as the heart tries to compensate for a loss in vasomotor tone. The patient's fluid status can also be assessed clinically by looking for evidence of circulatory overload peripherally, such as distended neck veins or peripheral edema and pulmonary edema. This may allude to a development of back pressure from either the left ventricle or right ventricle and allude to pump failure, either secondary to cardiogenic or, in certain instances, obstructive shock. Looking at blood pressure, a narrow pulse pressure again may be suggestive of a heart that is struggling to eject volume, whereas a wide pulse pressure may be suggestive of a hyperdynamic circulation with a loss of preload. There are also, of course, more specific signs of certain conditions that cause shock in the heart and lungs on auscultation and peripherally when trying to identify causes of sepsis that are too vast to cover in this talk. Regarding investigations, most of these patients are likely to get regular blood tests, looking for underlying causes such as troponins or BNPs, blood cultures, as well as evidence of end organ injury from more routine tests, such as development of AKI or an ischemic liver injury pattern. Regular blood gases often look at lactate and acidosis as a marker of poor end organ perfusion as the tissues enter anaerobic respiration. Previously, central venous oxygen saturations have been used with a number less than 65% suggestive of poor organ perfusion in the absence of hypoxia, although the evidence surrounding their routine use is poor. At this point, it's probably worth just mentioning lactate in shock. As you're all probably aware, lactate is a product of anaerobic glycolysis. Although there is a degree of anaerobic glycolysis occurring at baseline, most is metabolized hepatically and some renally. Generally speaking, you will encounter two main pathological reasons for a raised lactate in the ITU.
These can be separated into type A and type B. Type A is due to inadequate oxygen delivery, either from hypoperfusion, hypoxia, or less commonly, anemia. Think of the initial oxygen delivery equation that I mentioned earlier in this presentation. Type B is where there is no evidence of tissue hypoxia, and rather there is an imbalance between production and clearance. This can be related to hepatic or renal failure, certain malignancies, and drugs. Those which we may encounter on the ICU include adrenaline and salbutamol. Those which you may have encountered on the ward include drugs such as metformin. Lactate levels are directly proportional to outcome, with a lactate greater than 4 associated with a poorer outcome regardless of underlying cause, with the exception being raised lactate secondary to treatments such as patients on salbutamol or adrenaline. Serial lactates are often measured as a marker for response to treatment, particularly early on in a patient's ICU admission.
In the ICU, an arterial line will often be placed early on into a patient's admission. Not only will this give us beat-to-beat mean arterial pressures and blood pressures to help monitor the response to our treatment, the trace itself can also give us a huge amount of information. One important use in shock is to estimate whether or not a patient may be fluid responsive by looking at changes in pulse pressure, beat to beat, known as pulse pressure variation, and also an improvement in mean arterial pressure following a leg tilt, which can replicate a fluid challenge. The position of the dicrotic notch further into diastole can also indicate a vasodilated patient, whilst a notch close to the end of systole will indicate a more vasoconstricted patient. There are more invasive methods of investigating whether a patient's shock is likely to be fluid responsive or may improve with an increase in cardiac contractility. These include PICO lines and pulmonary artery catheters, although the use and interpretation of these is outside the scope of an introduction to ITU. At the bedside on ICU, it may be appropriate for a more experienced clinician or a clinician experienced in ultrasound to perform point-of-care testing as part of the circulatory assessment. This allows us to assess the ventricular filling within the heart, as well as estimate the filling pressures of the IVC, which is a surrogate for right ventricular pressure. It will also give us an idea of how well the heart is contracting and whether there are any obvious obstructions to flow, such as emboli, left ventricular outflow tract obstruction, or tamponade. Performing ultrasound of the lungs will also help us to assess fluid status and can also identify other causes of shock such as pneumothorax, infection, and pulmonary edema secondary to cardiac failure. This will allow us to tailor our therapy away from just giving recurrent fluid boluses to a range of treatments that may include fluids, but may also include therapies such as vasopressors and inotropes, which we'll go on to discuss. This picture shows how some of the different types of shock may present when volume status, cardiac function, and lungs are assessed. As you can see, significant IVC collapsibility may suggest pipe failure due to a loss of vasomotor tone or hypovolemia. A hypodynamic left ventricular function may suggest distributive shock, whereas reduction in cardiac contractility indicates a degree of cardiogenic shock, even if there are other underlying mechanisms also at play. B-line morphology on lung ultrasound will often be seen in pulmonary edema, although do not forget it can also be an indicator of other underlying lung pathology, such as infection as a cause of septic shock. A loss of lung sliding on lung ultrasound may be suggestive of a pneumothorax. I'm now going to move on to ways in which shock is managed. Unfortunately, for a reasonable amount of patients within the ICU, either by nature of their presenting complaint or due to the iatrogenic complications of an admission to critical care, the management of shock does not always fall nicely into one category, and therefore management often needs to be patient-specific, based on the findings of clinical examination and investigations. I'm not going to go through specifics of treatment based on the causes of shock. As a mainstay,
pump failure, either from cardiogenic or distributive shock, will require reversal of the problem, followed by possible optimization of cardiac contractility. And hypovolemic or distributive shock will initially be treated with a degree of cardiovascular filling, either with fluid therapy or blood, whilst also treating the underlying problem. All of these are done with the aim of improving end organ perfusion. Other measures to consider include minimising oxygen consumption by managing pain, fevers, possibly ventilation, and avoiding significant hypoglycemia. What I hope to do in this next section is just talk generally about some of the pharmaceutical options of vasopressors and inotropes that we may use to support patients with shock. Mechanical support of shock is something that is becoming increasingly popular, but is again outside of the scope of this talk. In order to make understanding these pharmacological agents for support of shock slightly easier, I think it's important to touch on a bit of physiology. Alpha receptors and beta receptors are G protein coupled receptors, which form an important part of the humoral response to changes within the cardiovascular system. Generally speaking, alpha receptors act on the vasculature, with alpha 1 tending to cause vasoconstriction, and these are our common vasopressors, and alpha 2 tending to cause vasodilatation. Typically, beta receptors have a greater effect on the heart, although they do have some effect on the vasculature and tend to cause vasodilatation. Again, broadly speaking, beta 1 receptors increase cardiac contractility, with beta 2 receptors increasing heart rate. I think it's important to stress at this point that often the term vasopressors will be used as a general term for all of these therapies. However, there is a difference between vasopressor and inotropy, which we'll go on to hopefully delineate. Rather than separate these drugs into the mechanism they work on by receptor action, I'm going to separate the drugs we commonly encounter into those which have predominantly vasopressor action and those which predominantly have inotropic action, as this will hopefully make it easier to understand in what conditions they may be used. I'll initially discuss those pharmacological agents considered as vasopressors. Metaraminol and phenylephrine are vasopressors that have alpha-1 action. They can be administered peripherally via infusion or boluses, making them a favourable treatment to be used outside of the intensive care, often in theatres on the wards as a temporising measure prior to central access for patients being considered for admission to the critical care unit. They are generally weaker, short-acting vasopressors that exhibit a reduced response over time, known as tachyphylaxis. This makes them a less ideal therapy for a patient requiring ongoing cardiovascular support, as our patients on critical care often do. Probably the most common vasopressor used in the intensive care unit is noradrenaline. It is a precursor of adrenaline and has potent alpha-1 action. It's usually administered centrally as an infusion, although weaker preparations can be considered peripherally, either as a temporising measure or for patients who are likely to only require a short period of vasopressor therapy. It is often commenced in shock to improve preload by increasing systemic vascular resistance. Be aware, though, that this increasing SVR may have deleterious effects in a pump that is already failing due to the increase in afterload, such as in cardiogenic shock. This is why assessing for underlying mechanism of shock can be extremely important, as previously mentioned. Dosing is usually calculated in mics per kilo per minute, with 1 mic per kilo per minute being considered a very high, if not the maximum dose. Often, beyond 0.5 mics per kilo, other therapies may need to be added. Vasopressin is often considered second-line therapy in patients in whom additional vasopressor is required. It's a synthetic version of the antidiuretic hormone, and it acts to improve vasoconstriction via its V1 receptors, as well as having some action on V2 receptors, which work in the kidney to retain water and may help to improve volume status in hypovolemia.
The dose is calculated in units per hour, with dosing generally between 0.6 to 2.4 units per hour. Adrenaline is slightly more complex to categorize, as it has both potent alpha and beta action. It can therefore be useful in types of shock secondary to vasodilation or pump failure. At lower doses, it exhibits predominantly beta effects, and at higher doses, predominantly alpha effects. Generally speaking, it should be given centrally, although it can be given peripherally via an infusion. In desperate measures, or for specific reasons such as cardiac arrest or anaphylaxis, as you'll be aware, boluses can be given. It is worth noting that due to its stimulation of glycolysis, a large amount of lactate can be produced, which makes lactate interpretation a difficult marker in a patient on adrenaline. We'll now go on to discuss drugs that have more of an inotropic action. Most of these drugs will be used in situations where there is a degree of pump failure in order to try and improve cardiac output by improving cardiac contractility rather than preload, although it's worth mentioning that optimization of preload should occur in concurrence with these therapies. Often, due to the fact that beta agonism can also affect peripheral vascular resistance, they may need to be used in conjunction with a vasopressor to avoid loss of preload due to a low SVR. Dobutamine is a beta-1 and beta-2 agonist that will improve cardiac contractility, which hopefully will improve stroke volume. It is used more commonly in shock due to cardiac failure, as it has both inotropic and chronotropic effects. It can be administered via a peripheral infusion as well as centrally, making it a good option for areas outside of level 3 care, such as CCU or the emergency department, prior to definitive cardiology involvement. Milrinone and enoxamone are newer drugs that work further down the G protein coupled receptor pathway by inhibiting phosphodiesterase, which is an element that breaks down cyclic AMP. Levosimendan is a drug with a long half-life that increases troponin sensitivity to calcium and therefore improves cardiac contractility. This table offers a nice overall summary of vasopressors and inotropes. The left side of this infographic demonstrates examples of what vasopressors and inotropic therapy may be used in certain situations, although, as previously mentioned, often shock can be more multifactorial in the ITU. Think of the patient with a known myocardial infarction who's admitted to critical care, who then develops a ventilator-associated pneumonia and sepsis during their admission. The right side of this picture is a nice schematic of the dual and often opposing actions of some of these medications, which is why you may often see a patient on multiple inotropic and vasopressor therapies. So to summarise, shock is secondary to inadequate oxygen delivery to the tissues, and if left untreated can be life-threatening. Hypovolemic and distributive shock result in loss of preload, reducing stroke volume and therefore reducing cardiac output. Cardiogenic and distributive shock results in a direct or indirect reduction in myocardial function. In undifferentiated shock, clinical and biochemical differentiators may be subtle, but point-of-care ultrasound can be a useful tool. As well as managing reversible causes, vasopressors and inotropic medication form the mainstay of treatment. Vasopressors are often used in hypovolemic and distributive shock, whilst cardiogenic and obstructive shock may require inotropic support. Hopefully, following this session, you now have a better understanding of the underlying causes and the best ways to treat shock, and you appreciate that it's not always clear-cut, which is why I cannot stress the importance of regular assessments of response to treatment and further clinical examination and investigation at regular intervals for these patients. During your time, you'll gain lots of exposure to the shocked patient, so I hope this has made you feel more at ease with both the recognition and management. Good luck during your time on critical care. Before I go, I just want to mention 3 really useful resources for anyone interested in reading a bit more into this topic or for furthering their knowledge on any topic around critical care. The IBCC, the Internet Book of Critical Care, is a book that can be found on the MCRIT website or comes in podcast version as well, where they break down aspects of critical care based on specialty. And is just a good overview really on these topics. Life in the Fast Lane, as you may be aware of, has a wide variety of resources, mostly focused on emergency medicine and ITU topics. And then the Critical Care Time offers a kind of deep dive into the more debated topics of intensive care. And although it's slightly Americanized, I find it really useful for those long commutes. Here are my references. Thank you very much for listening. If you have any further questions, feel free to contact me on my email address, which I've just put in the right-hand corner.